All right, it looks like we're at 10 o'clock. So thank you to our panelists and to the journalists who have joined us this morning. We appreciate your time. And we think we have a really interesting presentation for you this morning. Going into the month of September, we want to begin talking about some of the research that has taken place at Navicent Health as that relates to COVID-19. And so we're going to kick that off this morning talking about the use of TPA for respiratory distress in COVID-19 patients. Just a few housekeeping items to keep in mind. All phones except those of our panelists will be on mute. All cameras except those of our panelists will be turned off. Submit your questions at any time through the Zoom chat feature, and we'll be sure to ask our panelists that during the Q&A session. Our panelists will present this morning, and then we will go to that Q&A for the last half of our Zoom this morning. So for our panelists this morning, we have Dr. Patrice Walker. If you were with us 2 weeks ago, you may recognize Dr. Walker. She joined us when we talked about infants and pediatrics. She's the Chief Medical Officer for the Medical Center Navicent Health. We also have Dr. Benji Christie, a trauma surgeon and the surgical critical care intensivist at the Medical Center Navicent Health. Dr. Walker and Dr. Christie, thank you for joining us this morning. Dr. Walker, we'll let you kick things off for us this morning.
Sure. Good morning, and thank you for joining us for our fourth discussion panel. We will continue to host these panels each week. During the month of September, we would like to turn our attention to local research taking place at Navicent. As we all know, a novel virus and the first pandemic in our lifetime has presented the healthcare community with new and unique challenges, but also opportunities. And these opportunities lie in research. There are a number of research projects taking place at Navicent Health as we seek to determine the best treatment options for COVID-19. As a teaching hospital, one of the key aspects that our clinical faculty are responsible for outside of their daily teaching duties is the generation of original research. Now, this not only helps our learners from an educational standpoint, but it also benefits our patients locally, and as you'll hear in just a few minutes, patients outside of Georgia and across the nation and possibly across the world. We know that patients who receive care at teaching hospitals have better quality of care, they have access to new treatments and therapies, they have access to state-of-the-art technologies, they have better outcomes and survival rates, and they have access to the expertise of our faculty, physicians, and surgeons who have to be available 24 hours a day because they're teachers. And one of the fantastic faculty and surgeons that we have on staff here is Dr. Benji Christie, who you'll be meeting in just a few minutes. And the wonderful thing is we are able to provide this at Navicent in Middle Georgia. So it's not just the bigger cities and the larger academic institutions that can do this, but we're able to do it right here in Macon, Georgia. However, in many cases, we do collaborate with the larger institutions, and this is a good thing. In just a few minutes, Dr. Christie is going to describe some of the collaborations that's going to come out of the current research. And this is really important because we know the best research includes data from diverse populations of people that come from all walks of life and that live in various regions of the United States and even the world. The more inclusive the research group, the more widely applicable the results are. So today, we would like to highlight a specific research project undertaken by our trauma and critical care team. This project was recently featured in the Journal of Trauma and Acute Care Surgery and examines the use of TPA, or tissue plasminogen activator, for the treatment of COVID patients facing respiratory distress. Many Navicent Health doctors and teammates contributed to this study that was led by Dr. Benji Christie. I'd like to ask Dr. Christie to share more details about this study and how it can improve COVID care far beyond Macon and Central Georgia. Dr. Christie.
Oh, thank you, Dr. Walker. I appreciate the introduction, and thank everybody for their attendance and interest. It's flattering to get to talk to you today about this. The use of TPA as an adjunct for respiratory support the idea really developed early during the surge of COVID patients that began in the United States pretty much around the month of February. And there TPA, or actually these clot-busting drugs, have been used in respiratory models in the late 1990s and early 2000s. It's just with different patient populations and with drugs that were not necessarily as refined and modern as what we have today with some of the newer versions of the clot-busting drugs. And when researchers around the world started identifying that the COVID-driven respiratory failure has some similar features that are different than the respiratory failure scenarios we've seen over the many years, the idea that clots sort of filling the blood vessels in the lungs, making it hard to get oxygen, became a topic of interest and great debate on a global scale. With all the information that was able to be shared on a global scale, this theory did make a lot of sense and made a lot of sense to us. And we pursued using TPA in this non-traditional fashion to help improve patients' abilities to oxygenate, to get oxygen during an acute COVID infection. TPA is a drug that's used more commonly for stroke patients, where a stroke will have developed because of a clotting in the brain. And this is a very similar application of it, just with different doses over a different timeline. So we were able to put together the infrastructure, and thanks to our critical care team, which spans all the ICUs in our hospital, we're able to put together our guidelines and delivery instructions, and have been able to safely deliver the drug to a number of patients during our COVID experience. The patient experiences that we encountered, we tracked everything carefully. Every detail was recorded, and our first handful of patients and their outcomes were reported in the Journal of Trauma. And not many institutions in the country were able to pull a research investigation effort like that off. So we were pretty proud that we were able to do it and had some meaningful data to share. We've since continued to use the agent and have seen some impact, some clinical impact that I would say is positive, and we continue to study it. The TPA research is ongoing, and we are actually invited to be a part of an international collaborative to use our own data and continue to analyze other people's data for the sake of demonstrating, hopefully, what will be an improvement in patients' ability to endure the respiratory insult that COVID creates. So, other projects we have been working on is, as an institution, we have carefully cataloged all of our COVID patient encounters and are cooperating with the Society of Critical Care Medicine to create an international database so that we may look at all patients, all characteristics, and identify trends as it relates to infection susceptibilities and even outcomes. This database allows us to create a very homogeneous, sort of pure reservoir through which we can ask questions and then hopefully come to answers in order to help more people as this infection cascades around the world, continues to cascade around the world. Interinstitutionally, we have a steroid trial that we are evaluating different protocols to identify, is there one protocol that seems to work better than the other. And we've also worked through the convalescent plasma trial, where we were part of a data effort that was led by the Mayo Center. And we participated in data accumulation and reporting with them, and are now looking back at our own patients for the opportunity to gather controls so we can draw conclusions amongst how convalescent plasma influenced the patients in our region. So, a final study that we actually just submitted and is in the process of approval was for the evaluation of a serologic marker called D-dimer, which is really an inflammatory marker that indirectly implies that something that relates to clot formation or clot busting is happening in the body. And it's been identified from the Chinese literature early in the COVID experience that this marker is may have some impact as it relates to predicting disease severity and even outcomes. And so through our work here, we were able to track this marker specifically and have identified that it does seem to have a degree of predictive value as it relates to outcomes, and specifically in our patient population, and have recently created a manuscript that's right now being reviewed and hopefully will be published soon. So that's the thrust of the research that I'm aware of right now.
All right. Thank you, Dr. Christie. I do want to remind the journalists that have joined us on the call, go ahead and submit your questions through that chat feature if you have any. We have a couple that have come in already. Dr. Christie, you mentioned the International Collaborative. How far does this research project stretch globally? Where are the other partners hailing from? Can you tell us?
Yeah, I can tell you the majority are in the United States right now. The ones that are aligning right now with success in terms of being able to participate Beth Israel, and I believe I'm going to say this, but Beth Israel, Denver Health, University of Colorado, Harvard, and there's a couple other the names that slip my mind right now. But my understanding is there's other researchers in the UK in particular who are interested in participating, but everybody has their sort of regulatory barriers that they must go through, and I'm not familiar with. I'm unsure of their progress. I just know they have strong interest, but we're aligning up nicely, and looks like we'll be a strong contributor to this effort.
All right, and second follow-up question to that, when you began using the TPA for those COVID patients, what were the immediate results you saw in those patients? How did the patients react? Did the conditions improve?
So these patients are extraordinarily complicated, and they have a lot of organ system dysfunction happening at the same time. Can say that we noticed, number one, no harm, and number two, in patients, if you look at our cohort of patients, we did see some favorable trends in their ability to oxygenate, to gain and maintain oxygen. Now, the question that we're continuing to work towards, is this transient? Is this durable? Is the dose, is this the best dose? And what needs to happen after the delivery of the agent to keep the patient's ability to oxygenate at a high level? And that's as much as I can say about it right now. But we do have some positivity as we look at our data from an aggregate perspective.
All right, and you mentioned the TPA. You also mentioned steroids a few moments ago. Can you just discuss the different types of medications that are being used to treat these patients?
There is steroids initially, or early in the COVID experience, was sort of recommended against. Exactly where these guidelines came from, it's hard to know. Everything was moving so fast, and the theory was that it increased particle shedding. But as researchers around the globe became more familiar with patient outcomes after steroid use and without steroid use, the extreme inflammatory response that this virus creates, it was identified that steroids actually were of some benefit. Now the question becomes, what type, what dosing strategy, and what frequency would be best to deliver in hopes of creating the most positive impact. So in our institution, there's sort of two schools of thoughts, and they're both different. They're both steroids of a similar design. There's just different protocols through which they can be delivered, and no one knows what's best. We have seen satisfactory outcomes with both strategies, and then within our intensivist group, there are some who are strongly interested in identifying or believe that one strategy is better than the other, and we're trying to create that sort of proof now. Other medicines that are useful, unfortunately, there's not any proven medicine that is useful. There's no data that says one medicine is a cure, certainly, and most of the medicines we deliver are to care for some pre-existing conditions and or delivered in a supportive manner. I will say that we've used convalescent plasma, and like I mentioned earlier, we're kind of tracking patient outcomes related to convalescent plasma delivery. And other than medicines, the one thing I know that we do routinely, religiously, in fact, is prone positioning, which is where the patients with the severe respiratory infections, to improve the ability of all of their lungs to gather oxygen, we will, not just in the recumbent position, help support them, but we also will roll them to where they're on their stomachs to allow the lungs to receive oxygen, not just in the front and the base, but also in the posterior aspect of the lungs. And that is, out of all the delivery methods, care delivery methods on a global scale, that may be one of the most helpful things that is not necessarily medicine at all.
Really interesting. And we have a question here from Billy at the Union Reporter. Just how important is the research that you have done here at Navicent in terms of addressing a global pandemic, and the international or the local research being used internationally?
Helen, could you repeat that question? I didn't catch.
Sure, that's fine. As far as local research, how is the research being done at Navicent help? Hold on, let me make sure I'm reading this correctly. I'm sorry. How important is research being done in Navicent Health being used in terms of a global pandemic and the impact that it has internationally?
So I think if you look at research on this magnitude, every small bit fits to another small bit, and after all the small bits are integrated together, you have a large platform from which to understand or better use. So the while our contributions, from a global perspective, that's a couple of small reports, a couple of nice retrospective reviews with some significant numbers, by the way. I think globally, it'll be a voice around which others can hear and hopefully respond to. Hopefully others can share their experiences, that whether similar or different. And I think collectively, scientists and researchers around the world, as their voices sort of rise up from their institutions and amplify together, and hopefully we will hear or find a signal that directs us towards proper treatment and effective treatment.
Dr. Walker, we'd like to ask you the same question. On the whole, how is local research effective and impactful globally?
Right. I mean, I certainly agree with what Dr. Christie said. I think he said it very, very well, in that our local results are added to the larger medical community, and asking a question a certain way may lead to additional questions. So research tends to build on research. Many times at the end of one study, we end up with more questions than answers, but that's fantastic, but because that lays the groundwork for the next round of research. And so what will come from this is possibly better questions to ask next time, a better, different formatting of research. So it all works together.
All right, we have a question, Dr. Walker. It's not quite on the subject of research, but it appears that the numbers in Central Georgia tend to be trending down as far as positive cases. With Labor Day weekend approaching, should people continue to practice those safety measures like social distancing and masking?
Absolutely. While the numbers do seem to be trending down in this area, the pandemic is not over. It's not gone anywhere. So people need to continue to be vigilant, especially over a holiday weekend, when we tend to relax and want to let our hair down and we want to commune with our family and friends, but we still have to maintain all of the things that we've learned, the basic knowledge that we've learned thus far about universally masking, performing hand hygiene, and trying to stay socially distant when we can. Those three aspects are still to be maintained regardless of what the numbers are doing. And if we can do that, the hope is that we can have a safe and restful holiday.
All right, thank you, Dr. Walker. I just want to remind everyone to please submit their questions by the Zoom chat feature. We have about 10 minutes left here on our Zoom meeting, so go ahead and get those questions in if you have anything you would like to ask. Dr. Christie, going back to the use of TPA, we know that TPA is a clot busting agent normally used for stroke. Is stroke considered a side effect of COVID-19? And would the TPA also assist in reducing the likelihood of stroke for someone who had COVID-19?
That's a great question, and that's actively being discussed right now. I can say on a national scale, there are patients who are presenting around the country who's with no risk factors that are having strokes from thrombotic phenomenon. So they're having clots that are creating cerebrovascular accidents, and they are COVID positive. So the idea is that this same hypercoagulable state that the virus and our body's response to it seems to create would be their only risk factor for a stroke. And that's very concerning and a very alarming observation that's being made. Now more work has to be done to basically generate causality, but right now it is a very concerning trend, and a lot of people are discussing and identifying this as a risk factor. COVID-19 is a risk factor for cerebrovascular accidents that result in strokes. So can TPA prevent that? Well, the question is, if that's their presenting symptom, how can you get to them before they have the clot, so to speak, that creates the cerebrovascular accident, especially if this is the first symptom they develop. So that may be challenging, but the use of TPA is, by design, would be a solution for decreasing the clots that have formed, and hopefully decreasing the clot burden, whether it be in the lungs or any of the other organ structures, and allowing these organ structures to work a little bit better. So.
All right, thank you, sir. Just a reminder, go ahead and get those questions in via the chat. We're coming up toward the end of our Zoom here. Dr. Walker, if someone believes they may be positive for COVID-19, what steps should they take as far as how to get tested or how to receive treatment?
I lost you at the very end of that question, but I think I caught the gist of it. If someone believes they have been exposed, or if they have symptoms, so at this point, the CDC recommendations are constantly changing, but for right now, if you have a primary care physician, you can certainly call your primary care physician and get, get a consultation from the primary care physician. Short of that, urgent care or emergency center. Urgent care if your symptoms are relatively, mild. The emergency center if symptoms seem to be worsening. But the goal is to make sure that you quarantine yourself from others until you know the results of whatever testing modality is utilized, because until the assumption is you could be positive and you don't want to expose others. There's also still testing being performed through the Department of Public Health in various locations. Of course, there's a very large, testing center in Atlanta, but locally here, and we have testing at our Macon-Bibb Department of Public Health, and various other district health departments also have testing availability. You'll have to refer to the DPH website. Most of those require appointments. They would prefer you to not just walk in because they have a specific protocol, but testing availability has greatly increased over the course of the last few months. So we feel right now that we have good access to those that need to be tested. It's just a matter of what's the best route to go. So your primary care physician, many physicians now even have some of the rapid testing in their office. Urgent care, emergency center, or Department of Public Health are all good options.
All right, thank you. Dr. Christie, we know that research is a collaborative effort. Who were some of the other physicians or teammates that worked here at Navicent to assist with the TPA study?
There was a lot of people that helped work, because these patients we cover a lot of different geography, and we work with one another collaboratively on a daily and nightly basis. So just kind of staying on top of the medication that's delivered, as well as the patient and the care that's being delivered to the patient, was something that we all work very well with one another. But there's a lot of physicians, in particular, Dennis Ashley was a part, Dr. Suhab Khan, Dr. Aftab Ahmed, Dr. Erskine James, Dr. Charles Callender, some of the Dr. Hannah Nimick, Dr. Tony Scott. We had med students that were involved. John Buchanan was a very strong contributor to the study and continues to be as it relates to our database and the work we're trying to archive for this. Dr. Amy Christie, not to not mention her. Let me think. If I'm missing anybody, I certainly don't mean to. But it was a lot of people. We had collaboration from our pharmacists. And we had collaboration from our IRB. We had, a lot of people were interested and put their intellectual skill set and time into it, and we're all grateful for that. And hopefully, this will be something that can be built upon for the future.
All right. Well, we are drawing to the end here with our Zoom. We've got about 4 minutes left. If you have any other questions, please go ahead and get those in through the chat feature. To both of our panelists, is there anything you would like to add that we didn't cover today? Dr. Walker.
Just want to make sure, I believe Dr. Christie mentioned it, but just want to make sure that we don't forget about the remdesivir as another treatment modality for our COVID positive patients. We do have access to that here at Navicent Health. We have specific protocols that we are utilizing for the dosing and for the days of treatment, but that is a widely publicized method of treatment. Still experimental, like all the other things that Dr. Christie mentioned, but certainly an avenue of treatment that we have access to and that is still being performed. So we do have that availability for patients here at Navicent.
All right, thank you so much for bringing that up. Dr. Christie, is there anything you would like to add?
I forgot to mention Dr. Christopher Franklin as a contributor to the research work we're doing in this hospital. And if I forgot to mention anybody else, please forgive me. But definitely wanted to mention Dr. Franklin as he was a big part of the brainstorming and study design that we've been using. So.
All right. Well, I want to thank you both for joining us this morning. I want to thank the many journalists that joined us on the call this morning, and thank you for those questions. If you have any follow-up questions after this Zoom is over, feel free to email me at allen.megan@navicenthealth.org. We'll be happy to get those answers for you. If there's anything else that comes up, of course, you can also reach us there. And thank you all. I hope you have a great morning and have a blessed weekend and good holiday weekend. Thank you.
Thank you.
Thank you.